Welcome to the Birmingham Longevity Podcast. I'm here with our esteemed medical director, Dr. Jerry Kitchens.
Good morning, Drew.
Thanks for coming.
Yeah, absolutely. Well, I was here anyways. Just a short walk down the hall.
Thanks for chatting with us. Today, we're just going to be giving an overview of kind of what our process looks like through testing and evaluation, kind of how things look different than what people are normally used to, but also kind of going in depth a little bit on the specific tests
Okay.
that we do. Um, but to start, I just wanted you to give me a general overview of what your functional medicine consultation looks like and how that might be different than what people are used to with a typical medical consultation.
Okay. So we start with a meet and greet in the lobby, which is very beautiful and comfortable. It's a very comfortable surrounding. And then we go directly to the physical exam room. And the reason I do that is, and this is partly because of feedback from my wife and her GYN visits, is it's not much fun to sit around an exam table and go through your history and everything else. It's uncomfortable, and especially if you had to disrobe or something like that, and then you're sitting around having a conversation. So we do all the physical exam and get that out of the way. Uh, Not out of the way in that it's not important, is very important, but then we like to transition from the full physical exam to a separate room where we sit in comfortable chairs. And actually, we're in that room right now. We're not in the comfortable chairs. We're having a conversation, but very comfortable spot with beautiful scenery, beautiful green trees, lush vegetation. So you can decompress, get over kind of the anxiety. If you have white coat syndrome, there's no white coats, there's no, you know, physical exam instruments or anything to really be afraid of. And then we engage in a long conversation that lasts about an hour and a half. And we start from the moment you're in your mom's womb and we go all the way to today. And every important, impactful event in your life is documented. Includes medical events, but other types of traumatic events that may have shaped your health afterwards.
Yeah. Yeah. So you're not just looking at, okay, what is this person's primary complaint, but how can that complaint be influenced by something that even happened in childhood?
Absolutely.
Yeah. Yeah.
So functional medicine is really root cause medicine.
Yeah.
You can take a hammer and play whack-a-mole and hit the type 2 diabetes mole, and then you can hit the hypertension mole, and then you can try to hit the heart disease mole, and but they share a common root cause. Metabolic dysfunction arises out of really our industrial civilization and highly processed foods, lack of activity, a lot of lifestyle choices that lead you down the road to developing those diseases. So we like to document all of that so we can get a roadmap to get you back on the road to wellness.
Yeah. What are one or two like common things that you hear from some people's history that sort of drive problems later in life? Like maybe from when they're younger?
It varies, but I'd say a common thing from my generation of people is they grew up in a household where one or two parents smoked. They had a lot of exposure to secondhand smoke growing up. Um, there was this transition in nutrition when we were growing up where the whole food pyramid got flipped upside down, and there was a stress on increasing the amount of carbohydrates you consumed, which we now know is not a good decision. It leads to type 2 diabetes. And it really led to our issues that we see now with this wave of obesity that you even see young kids that when we were growing up were always skinny because we were outside running around all the time.
Yeah.
And now you have a lot of obese young people that are suffering from prediabetes or type 2 diabetes before they leave high school. So I would say the transition from a smoking society to now a much less smoking society, although they've replaced it with vaping, which I think's every bit as bad for your lungs. But also just the prevalence of shelf safe food that's available to people. It's inexpensive, it's calorie dense, but it's terrible on your body. And for a lot of people, it's their only option they have. They don't have enough money to buy organic produce and do the things that you need to do. So I would say that those are kind of the things we see. And then usually there's some events that happen in childhood, whether it was an infection, you had recurrent strep throat, you were treated with a bunch of antibiotics that led to dysbiosis in your intestines that created all sorts of inflammation, and you've been suffering from inflammation since that time. Those sorts of things are just red flags that say, okay, we need to take a deeper dive and really look at their microbiome and see are they in balance or do we need to work on that?
Mm, yeah. You mentioned inflammation. I feel like that's a word that's been thrown around a lot recently just because of obviously the importance of it, but how do you guys look at inflammation? What is inflammation at its core, and kind of how does that kind of affect what you look at and what you treat with somebody?
That's a great question. So inflammation at its basic level is how we survive.
Yeah.
I mean, you had a cut, when you're out hunting the woolly mammoth, and your body developed an inflammatory response to that, that then led to wound healing, deposition of collagen and wound healing, and help fight off infections and things of that nature. Um, what isn't helpful is when certain proteins are presented to your body's immune system and are identified as alien to your body. And then the response is not only to whatever that protein that was put in front of the immune system, but also to a similar protein in your body. And so we see that with oligosaccharides, well, not really, polysaccharides more than oligosaccharides in bread. Patients that have leaky gut can present these complex carbohydrates to the immune system, and then the body reacts to that and it creates inflammation in the body. So, inflammation to heal or to fight off an invading organism is life saving.
Yeah.
Inflammation that causes destruction of your cartilage in your joints or causes inflammation in the wall of your arteries that then lead to coronary artery disease is not helpful at all. And so, finding the source of that inflammation and targeting it and helping your body recover and taming that inflammation is the way you get into a healthy lifestyle and lifespan. And so, we target inflammatory markers to kind of give us a feedback on how well we're doing, and a couple of those that are really simple tests, blood tests, are homocysteine and high sensitivity CRP, is labeled HSCRP. But those measure how much inflammation is going on in your body.
Okay. Yeah. Yeah, I guess not all inflammation is bad just from even a physical side of things of you need inflammation to heal. You need inflammation to heal injuries and to grow muscles and get your bones stronger and everything, but you're saying you're more focused on specific inflammatory markers and how that can influence somebody's health.
Yeah, and just the markers are just there just as a measuring instrument to tell us whether we're being successful and how we're targeting our treatment. Um, but I would say that in general in our society today, most people are inflamed to some degree or another. And we see it in their complaints when they present to our clinic. They lack energy. They're not vibrant. They've got brain fog. Their joints ache. They're, putting on weight despite everything that they try to do. All of those things are signs of inflammation. And I think inflammation is the common thread for a lot of the diseases we see that reduce your ability to lead a healthy life and lead to struggles later that are contrary to what we're trying to provide for our patients.
Part of our testing process is obviously people go and they get a few different scans done before they come see us, and you guys go over it with them kind of in person that first visit. One of those being the CTA. So tell me, what is a CTA? What do you use it for? Why is it important?
So we do a coronary CT angiogram, and it's basically a 3D cardiac cath. It's able to pick up plaques that you may not see on a cath because we know that blood vessels accommodate to plaque formation, and by accommodation I mean as the lumen narrows with the plaque, in order to compensate, the body relaxes the vessel. So a blood vessel is really a muscular tube that's then lined by a layer of cells similar to your skin, but it's called the intima. And that muscular layer is able to relax and expand to allow blood flow to continue up to a point. Eventually, it's stretched as much as it can, and then you start to see the narrowings on a cardiac cath. A CT angiogram can pick that up earlier. And the other nice thing about CT angiogram is calcium scores can be misleading. You can have calcifications. Say you've been on, like me, have been on a statin for a long time. You can have calcifications in the wall of your vessels, and the question is, does that mean you have active disease that needs to be addressed, or was that old disease that was treated? Um, and so just to give my personal account, I ended up having a CT angiogram to to as a follow-up study, and only had one small distal lesion, about 20% of the lumen, and that was very reassuring for me. And I think it's reassuring for our patients because one thing that can really throw a wrench in the works if you're trying to achieve longevity is to have a widowmaker. That's sudden death, and there is no longevity with that. And so we like to identify the things that we know that if we intervene, we can provide that longevity as far as their heart health goes.
Hmm.
So that's basically that in a nutshell. So you lie on a CT scanner table and they hook up an IV and they give you contrast. Your heart rate's low. Generally, you've been given a beta blocker to slow your heart rate down so the imaging's more accurate. And you can feel some warmth and flushing. Of course, we like you to hydrate to make sure your kidneys do well with the study. But it's not a long test. And we'll have the results within 24 hours. And we can say, hey, everything looks great. Or if not, we can say, well, the next thing we do is to fix this lesion so that you don't have to worry about waking up in the middle of the night with crushing chest pain and it's too late. So we can intervene and change your trajectory.
Yeah. Yeah. Super important. Really cool stuff. Um, Another scan we're doing kind of when people come in is the ultrasound. I think a lot of people are familiar with that with pregnancy and all that sort of stuff. But how are you guys using the ultrasound scanner? What are you looking for exactly?
So are the ultrasounds here if there's a need to do an ultrasound, and so we don't routinely ultrasound just as a screening tool, but a lot of patients you'll see have thyroid issues, and may have thyroid nodules, and we can ultrasound and tell whether it's a colloid cyst or a solid nodule that needs to be biopsied. We actually have the ability here in the office to do a fine needle aspirate of any nodules like that and send that off to the lab, and the cytologist looks at us and they can tell us whether it's a possible thyroid malignancy or it's just colloid, and colloid's just protein. Um, and then we also, like, if you have palpable lymph nodes, we can ultrasound the lymph nodes to see what they look like, and we can again put a needle in it and aspirate some cells and send that off and look at it and see, is this a reactive lymph node, meaning there's some sort of infection, whether it's an ingrown hair follicle that's inflamed that's caused this enlarged lymph node. And so you really just have increased inflammation causing enlargement of the lymph node. Or is there something, a little more suspicious going on, like a lymphoma or potentially a metastasis from a cancer somewhere? So we can do that here in the office. We also have the ability to, look at blood vessels. I'm not certified to do Doppler studies for purposes of diagnosing, say, carotid artery stenosis, but we can look at things to make sure that they look good. And any sort of solid lesion we feel or soft lesion we feel, we can tell whether it's a cyst or something that we need to take care of.
Yeah. With the DEXA scans specifically that we've been doing more recently, it's giving us things, body fat percentage, visceral fat versus subcutaneous, muscle mass, all that sort of thing. The average client that comes to see us, what are the biggest few values that you're looking at that the DEXA scan gives us?
Well, I mean, first of all, most DEXA scans in this country are done for bone health, so we get a bone score. So, are you do you have osteoporosis, or you have osteopenia, at risk for osteoporosis? We want to make sure your bone structure is healthy. We know as you age, if you have a hip fracture, in your 60s, the mortality rate's not insignificant that
Mhm.
first year after
Yeah.
a hip fracture. So we want to make sure that your bones are healthy. But then the next thing I look at is lean muscle mass versus fat, and is their fat percentage in an acceptable range? We know, and I'll quote Peter Attia's kind of aha moment when he wrote Outlive was finding out that what he thought was just really great musculature was what he called a well marbled steak. He had his DEXA scan done, and he's like, "Wow, I've got a lot of fat in my muscle." So fat can hide a lot of places. Fortunately for most people, fat in your muscle is not as deadly as visceral fat, and that's that belly fat. And we see people everywhere today that have, generally probably skinny legs, skinny arms, and this big protuberant abdomen. Those don't need a scan for you to know what's wrong with them. But for those that are just starting to develop it, it's a great test to identify where your fat is. And it's classified into android and gynoid uh, deposition. And so android is visceral fat, it's fat in your midsection. Gynoid is more around your hips and upper thighs. And that's lower risk of developing type 2 diabetes and metabolic syndrome than the android kind of visceral fat. So we look at all of that and we just get an idea where you are. And the best part about it is, well, then you have a measuring stick
Yeah.
that we can measure when you come in for your quarterly follow-ups to make sure we're moving the needle with our plan. Because generally, we're going to put you on a healthy diet. We're not necessarily dieting, trying to crash diet and just lop off calories. We're trying to get you on a diet that's going to be anti-inflammatory. And in particular, the most common diet we recommend, and the one that's probably the most studied diet, is the Mediterranean diet. It lowers inflammation. You generally don't gain weight if you're active.
Mhm.
But being active is the other part of it, and that's where you come in. The work you do on the physical performance side
Yeah.
is very helpful for them. But for the patient to be able to see that things are improving helps them to stick with the program.
Yeah.
If you just say, well, go do this, and they don't see any results, then eventually you just tap out and say, okay, well, that's not helping. I'll go do something. I'll go sit at the beach and drink margaritas
Yeah.
and not worry about it. So we want to be able to show them that the initial small wins, but then the big wins. When you look back over the year and see how much you've improved your health, all your numbers are better, and your percentage fat's gone down. You don't have visceral fat issues anymore. You've eliminated your risk for type 2 diabetes, hypertension, heart
Yeah.
disease by just changing your lifestyle.
Mhm. Yeah, and that's really interesting too is, we can see even from my standpoint of view, if we can see people's maybe their weight doesn't fluctuate a whole lot, say they're kind of in that middle ground, but they need to get stronger and gain muscle and lose a little bit of fat, that their weight might not fluctuate but 5 or 10 pounds, but we can see their body composition change with lean mass and fat mass, visceral fat, all those things that they might not. It's like, "Hey, the scale really hasn't moved a whole lot, but visually and internally, I'm changing a lot." So I think it's a really valuable tool for us to have and track over time.
I agree, and also, I guess, I caution the patient that especially if you're younger, where you really can build muscle aggressively, your weight may go up because
Mhm.
muscle weighs more than fat. So your weight may go up, but your body composition is because your body composition is better. And we know and we preach that, muscle mass drives your metabolic rate. You burn calories based on how healthy your muscles are and how many that's where most of the mitochondria are hanging out. And they're what's chewing up the sugar in your blood and helping, keep your blood sugar in control. And they're what reduce the number of calories that are available for fat deposition. So
Yeah.
if you're muscular, you may weigh more, but our imaging will prove to you that your fat percentage has gone down. And
Yeah. Yeah, I've heard you guys say before, just because you're if you have more muscle mass, you're essentially just burning more calories without doing anything, just sitting there versus somebody who has less.
yeah,
And
and I
it's
guess I should explain, basal metabolic rate is what you're burning just sitting there. I mean,
Yeah.
you hadn't even cranked the engine yet. You're really well, maybe your engine's always cranked when you got lean muscle mass. So it's just idling in the background, but you're just at idle, and that's what you're burning. And for somebody that's really fit and has a fair amount of muscle, I don't know what your basal metabolic rate would be, but I bet you probably burn 1,800, 1,900 calories just sitting here. Like,
Yeah.
just sitting here talking, you may even burn more. And I'm moving
Yeah.
my arms a lot, so I'm burning more calories than you.
Yeah,
But
the report that it one of the reports it gives us a ton, but it gives you that basal metabolic rate of like, hey, if you were to lay in bed all day, this is what your body is using as energy. Like it needs this much for your organs to function and for you to not move a muscle or do anything. Which I think is valuable for people because then that gives them a baseline to not crash diet and to not be in such a low caloric deficit that they're under eating.
I agree,
Yeah,
because one of the biggest sinks for energy is your brain. I
yeah.
mean, it's a small organ compared to the rest of your body, but
Mhm.
it's using 25% of your calories.
Oh,
I
wow.
mean, it's just, it's going, blowing and going all the time. You don't want to deprive your brain of energy and nutrition, nor the rest of your body for that matter.
Yeah,
The nice thing about building lean muscle mass and increasing your basal metabolic rate is it's kind of an easy win to help you lose weight because your body's helping you do that. It starts burning more calories naturally, and then once you get used to it, what feels like a big hurdle at the beginning of this process of getting active becomes easier.
yeah, definitely. On that same note with brain health, total body health, another big thing we do is our genetic DNA test. Talk to me a little bit about not just what you guys are looking at, because I know it's hundreds of thousands, if not a million DNA SNPs that it's giving you, but how is this test that we do here maybe different than one that's available off market to kind of anybody, and kind of what are y'all using the test to do?
Okay, so yeah, there's so much that's happened in the past 5 to 10 years in the genetics world. It's amazing, and you anybody that did 23andMe, which is of course now defunct, but or any of those services that allow you to do your genetics for say your family tree or whatever, what's my makeup. They were also running studies on your epigenetics and what are called SNPs, single nucleopeptide polymorphisms, just little mutations in the strand of information that isn't those main genes that determine, say, hair color, eye color, how big you're going to be, uh, male, female, all that, are your main genes. But these epigenetics control enzymes that help turn things on and off. And that world has been growing. I think when they first started offering that with these random genetic tests out there, they were testing for maybe 500,000, but they're testing for over 1 million now. And our DNA analysis we use, they test for well over 1 million. The advantage we have is twofold. One is there's a separation of where your DNA goes, the analysis, and your identity. So there is two separate companies that. So your raw data is generated on your DNA, and it stays with that DNA analysis company with no link to who you are. And then the raw data is sent to the company that does the interpretation. And it was founded by two physicians, and its approach is a clinical approach. So it's not looking at SNPs just from a lay perspective. It's uh, physicians with experience in dealing with cognitive issues and everything else. And so the reports we get have all sorts of citations from the literature. They have interventions. They have the implications of those SNPs. And you get a report, and we get to personalize your plan so that that treatment works for you. And it's amazing the things that you find out. And when I had mine done, that I found out about myself that some things I was doing that I was doing for other reasons, I found out were affecting, 5 or 6 SNPs and helping improve my risk of certain issues.
Mm.
And other things I was doing, I found out weren't helping me at all because my body had a SNP and I wasn't able to, say, process this specific B vitamin. And so I needed to take a different form. Um, and it goes well beyond that. It's just an incredibly deep dive, and it really just shows the miracle we all are and how each person is unique in the history of creation, never to be repeated. And so their treatment has to be unique because there's will never be another person exactly like you or like me, maybe like Wilson, but not like you or like me.
You are definitely unique.
Mhm.
Yeah. Um, yeah, no, that's great. So that's something that we take the swab once they come in, for your
Yeah,
initial evaluation.
it's very
Yeah.
simple. It's a swab of the cheek. You swab your cheek for about 45 seconds. You break off the stick and the fluid, and we send it off. Again, it doesn't have your name on it. It just has a barcode, and then that kind of does its magic. And it takes a while to get the report back. So it's generally 6 to 8 weeks before we're ready to sit down and have a deep dive. And after this podcast, I'll be having a meeting with the patient to go over her genetics, and we've already created a plan for that. So um, it's incredibly neat. I mean, I would use the word cool because it's really
Yeah.
cool that you can do that. And so when I've said earlier, the sky's the limit, I just feel like the sky's the limit. We're on the cusp of so much advancement in healthcare.
Yeah.
And this company we use is getting ready to come out with an AI model that's going to be able to just kind of grab all the information in the universe of healthcare related to each of those SNPs and then bundle that all together into a package that, you know, gosh, when I was growing up, you had to go to the library and, go find books and get citations when did a paper. Now people can just go, hey, Chat GPT, write me a paper on something and just check it, make sure it's accurate and is it done, which I don't think is great. I think you should have to labor a little bit. But the fact that we're going to have tools that can take, these millions of permutations of human formation and create a individualized plan, help us create an individualized plan,
Mhm.
is just remarkable. We're on the cusp of that today.
Yeah. Going off of that, what are some of the, if any, the limitations of genetic testing? Like, how do you keep people from viewing maybe certain parts of their genetic panel as their ultimate destiny?
Well, we found out that genes for most disease processes are really only responsible for 20% or so of that risk. And the other 80% is up to us.
Mm.
So your future is really in your hands. Now there are some genetic mutations that just are tragic mutations that result in early death and all sorts of issues that we don't have treatments for. But but the SNPs that we are doing are easily modifiable. Now I say easily, meaning that we have a plan.
Yeah.
Of course, the hard part is always the patient has to do it, and so in our clinic we like to say and tell our patients, look, we're going to provide the roadmap, but the heavy lifting is on you. We're
Mm.
walking it with you,
Yeah.
and we eat our own cooking. I mean, I'm living it every day. I know you are.
Mhm.
I know, Wilson and Mark are. All of us in this clinic are living it every day. We get up in the morning, we exercise hard, and come in here. We try to eat right, um, and do the right things. So when we lay out a roadmap, that's when the real journey for the patient begins.
Yeah.
And if you're a go getter about longevity and health span, which, man, I look at it like, man, why wouldn't you be? Who doesn't want to live a vibrant life till the bitter end, just like the Blue Zone people? And then at the very end, it's over and you've had just this long, productive, fun life. Uh, it's worth whatever you have to put into it to get there.
Yeah.
And for those are watching this podcast that have seen the Blue Zones, I mean, my favorite guy is the man in Costa Rica who's over 100 years old and gets on his horse every day and herds cattle. And then in the evening, he goes to town and eats a nice meal, has a beer, and dances.
Yeah.
And, you know, that's a great way to live to be 102.
Mm.
Unfortunately, in our country, most people are spending those days sitting in assisted living or skilled nursing facility and just kind of watching the years kind of fade away. Um, and that could still happen. I mean, something tragic could happen, but if you take the bull by the horns, there's a great opportunity to live a super vibrant life up to the bitter end.
Yeah. The last thing I wanted to touch on, and you've already spoken about it a little bit, but is our blood panel that we do, for when members join. Um, Talk to me a little bit about what is on that panel and how it might differ from a typical primary care, like, yearly visit, like, general labs that people might have, gotten in the past.
Um, I would say that I guess primary care panels vary. I mean, I've had extensive panels done. Of course, sometimes at my request, I got, why don't you check all these vitamins and everything. I would say uh, checking vitamin levels probably not done routinely. I think it gives us a lot of information. And some of the vitamins you can glean what their levels are based on their makeup of their red blood cells and things of that nature. But so we do the basic things that you would get at a primary care doc's office, which would be the CBC, which is your blood count, and what's the makeup of your white blood cells, and what's your platelet count look like? What do your red blood cells look like? And do you like you have iron deficiency anemia, or are you macrocytic, which would be a low B12 level, things of that nature. And they do basically a serum analysis, which would include basic electrolytes, the things that we need to function every day, their sodium and our chloride and our potassium and CO2, and how well your kidneys are functioning, and liver functions to test, how well your liver's doing. Um, and then I get in most primary care once a year, we'll do just a basic lipid profile. Ours is much more extensive, and we're checking, apolipoprotein A and B, and we're checking the inflammatory markers we mentioned earlier, the homocysteine and the C-reactive protein. And we have targets that are lower than the normal range. I mean, we're looking for homocysteine of less than 8, and we're looking for C-reactive protein less than 1. As really signs that your vascular inflammation has been reduced. And then we check hormones, and we're big believers in optimizing hormones. We're in a period of time where over the past 30 years, to speak to men's health, over the past 30 years, the testosterone level in young men has dropped significantly, and the fertility rates have diminished. So we need to say a prayer for Wilson, um, but it's tragic, really, and a lot of that's microplastics, and we could do a whole podcast on microplastics and toxins in our society, and we live in a toxic world. But I'll just say, don't drink water out of a plastic bottle. Filter your water. Do everything you can to avoid microplastics. And but so you've got 30 somethings walking around with testosterones that we used to see in 80-year-old men. So checking hormone levels is important. And we know that testosterone is essential to maintain cognitive health. Having a normal testosterone level is necessary for your brain to function normally. But it's also necessary to maintain muscle mass. And you're the performance side, but as well as anybody that you have to have testosterone for bone health, for muscle health, and for brain health, and just to feel good. It helps you feel better. And for women, it's the same thing. And women need some testosterone to help maintain their muscle mass, their bone health, and also is protected for their brains. So we check all of that, whether you're male or female, in our clinic. So we do the full hormone panel. We check cortisol and all of that. So we want to see how's your endocrine axis working. Are all your sites that are producing hormones working normally, or has there been something that flipped the switch and everything's disordered? And so then when you have to start flipping switches back, turning things back on so they work normally.
Yeah.
So I think that's probably more extensive than most primary care visits would generate for a regular routine visit. I would certainly not go so far as to say that, if you're doing a deep dive, that they're not going to be ordering those things. If things are really wrong, they got to find out. They'll get
Yeah.
it done. Um, And then we could check things like rheumatoid issues, look for rheumatologic conditions and those sorts of things. So it's an extensive panel.
Yeah. Yeah, and I appreciate you kinda going through that. I know it would be borderline impossible to go through every single thing that we look at, Birmingham Longevity, just from a time standpoint, but I feel like that hits a lot of the main points. But any closing remarks for people?
Well, I'll say also, just to get back on the labs,
Yeah.
when we get your genetics back, sometimes the genetic results uh, help us target additional lab tests that are way out of the mainstream. You would not normally check certain things,
Hmm,
but you'll get a genetic result that says, wow, we need to be following this. And I would have never thought I would have had to follow this in this patient. But
yeah,
because of this SNP they have, they're at high risk if we don't maintain, say, the patient I'm talking to today has this SNP where you can deposit excess zinc in the brain that can lead to cognitive decline. And so their window of where their zinc level needs to be is lower. Uh, I wouldn't have known that without getting this genetic report that we need to target a lower zinc rate and be intentional about it, because if we don't, we're putting this person at risk for cognitive decline. And
yeah,
you know, if you live a long life and you don't know you're living a long life, that's not healthy either. So we want you to be, cognitively performing at your peak, physically performing at your peak, and just to be available to enjoy the, life and the fruits of the life you've lived with your kids and grandkids and all of that. Um, we want to create that future for you to live a vibrant life.
yeah, yeah. Well said, well said. Thank you for your time. We appreciate it, and
True.
we will see you next time. Thanks, everybody, for listening.
Sorry I threw Wilson under the bus a few times, but